In this case, it wasn't prior rhinoplasty, but trauma, which resulted in the appearance you see here, a rather twisted appearance to the nose where the upper portion of the nose and mid portion have been deviated to the left side. If we did a cross-section of this, we may see something in just a few minutes, like is shown in these drawings. With rhinoplasty, in this case, we have the nasal bones being fractured in towards the midline from the right towards the left, collapsing the nasal airway. Sometimes this can occur with overzealous osteotomies, which are what we perform to purposefully chisel the bone down to size in patients with wide nasal bases. If not done correctly, collapse of the nasal airway can occur. Nasal osteotomies are a talk unto themselves. Suffice to say that I believe that osteotomies are one of the most difficult aspects of rhinoplasty surgery to understand, as much of it is done without direct visualization. And also, I'd say it's just as much an art as it is a science. Well, we've talked a little bit about some of the things which can go wrong. Let's talk about some of the things which can go right. In addressing rhinoplasty with patients, it's important to analyze the patient, as I mentioned earlier. It's also important to understand exactly which areas of the nose need to be addressed and communicate with your patient so that they understand what your goals are and that they agree with those goals. The structural issues who had prior rhinoplasty surgery, which are basically due to problems with the anatomy of the nose. That his and this is the focus of my talk today. In this case, I agreed with Bony or cartilaginous deformities, which was here we see that his nasolabial angle is at or less than 90 degrees, which, as I mentioned earlier, is probably on the low end of the aesthetic norm for a man. His mustache probably isn't helping with that, but he wanted to keep that. So we performed a rhinoplasty operation. Our primary goal here was to rotate the tip. And a simple rotation of a few degrees with a little bit of tip definition makes a big difference for this gentleman's nose. One of the more common complaints when patients come into the office is a dorsal hump or a bump on the nose. These bumps can be composed of both cartilage and bone. And again, it's important to understand how much of a reduction you want to perform with your patients. It's easy to over-reduce these patients and give them a scooped-out appearing nose. It's also easy to underdo them. So it's nice in preoperative evaluation to talk to your patients and get an understanding of what their goals are. In this case, the patient wished the hump to be reduced slightly so that she maintained a strong profile. The familial trait to the dorsal bump was not something she wanted to eliminate completely. So a conservative hump reduction in males by open rhinoplasty approach, and she generally with a very nice result, 90 to 105 degrees. Often patients in females have the nasal breathing 95 to 115 degrees mention that there are some things about the shape of their nose that they'd like to have fixed. Furthermore, the patient's height is inversely related to the amount of rotation actually could not breathe through the nose. A taller person might do a septal deviation and some internal valve collapse, too much tip rotation. And likewise, he also wished to have the tip area refined somewhat. In order to really understand this better, in my preoperative planning, I used computer simulations to understand what his nose might look like with a little bit of tip rotation and tip definition. Even these subtle differences do make a difference for his nose, and this is the final result after nasal surgery on the right-hand side of the screen. This is another patient who wished the dorsal bump to be reduced and wished to have a more perky nose, so to speak. In this case, computer simulation was used to give us an idea of what this might appear like after surgery, and the final result is shown on the right-hand side of the screen, which makes a big difference for this patient. The rhinoplasty procedure can be done via multiple different approaches. All of the different approaches are outpatient. Patients go home the same day. I generally avoid internal nasal packing. I think that it's more comfortable for patients to avoid this, and often with proper techniques. It's a bony cartilaginous framework with a skin. A nasal splint is an external cast, like so to speak, with tape that's placed over the nose scaffolding underneath and is left there for 1 week's time. The scaffolding of the nose is actually composed of bone and cartilage. The final results take 6 to 12 months to be official. For example, up above we have the nasal, because even a small amount of swelling in the nose can make a big difference in terms of final result. However, even after the cast comes off, immediate differences are noted, and within 2 to 3 weeks after surgery, bruising and edema is virtually gone, and patients can generally get an idea of what the result will look like. Again, the goals are to create a harmonious, aesthetically pleasing appearance to the nose and to the face in general. And it's important in preoperative planning, again, to make sure your patients understand what your goals are and that they are in agreement with those. And again, it's very important to retain or improve nasal function during rhinoplasty surgery. excessively large appearance or dorsal hump of the nose, which we'll talk about in a little while. Deviations of the nasal septum, either the bony or cartilage, they can also swell more permanently due to allergic insults or other toxins, which we mentioned earlier. Often what about bony deformities of the nose?